what we thought, but you've just shown phenomenal results and showed what was expected. But I think that's an amazing study, and I've certainly been blown away by that. We'll have any comments or questions, guys. You can either put it in the chat group or you can raise your hands. Any questions or queries for Alex? Herman, did you want to say anything? If you want to unmute yourself.
Just Alex, thank you very much. Fantastic presentation. Would you envisage the same results with the oropharyngeal and anal cancer as well, non-gynecological malignancies in years to come?
So I don't think so, just because the proportion of those cancers that are due to HPV is much lower, much lower. So you will see some effect, but on the top of my mind, I can't tell you what the proportion is, but it's definitely maybe less than 60% that are due to HPV.
Thank you.
Any other comments? I don't think there's any other comments so far. I'll just ask your thoughts, Alex. What do you think about the age of screening? Do you think that's the appropriate age of screening? 25, in that, because you mentioned briefly part of the your results were as a result of the screening age having been changed. What's your take on the screening age?
Oh, I'll disclose to you that most of my working life has been assessing whether that was a good decision. I think it was a good decision to move it up, but I think there now needs to be thoughts about moving it further up, especially if we do see high vaccine uptake. You know, there'll be hardly any cervical cancer in younger women, but I guess that's still up for debate.
Okay, so you think it's the right thing to do?
I do, yeah.
Fantastic. Okay. Any other comments or queries, guys? Christian, a hand up from Christian. Do you want to unmute yourself and then put your camera on, please? Just give me 1 second. Let me just I've got everybody. Attendees' mics have been muted at the moment, so I'm opening those. Yep, go for it, Christian.
It's just that when we look,
put your camera on.
We regularly review the cancer cases at Kettering, and the trend that we have noticed, of course, a great presentation, Alex, but certainly the cervical cancer rates have fallen, but the cases that we're seeing are British women who have not engaged in the screening program, and of course the few sort of Europeans who have come over from countries where they have not been a cervical screening program. Those are the cases we are seeing locally here. Just a comment.
Great question. I guess what I did want to say is one of the things we're most worried about is this inequality. So what we're going to see is real inequalities of women who don't get vaccinated, don't attend for screening, have really bad outcomes.
Okay. Do you want to unmute yourself and put your screen on? Thank you, Christian.
Thanks, Alex. Really interesting data. I just have a question on the genotyping. So for the you've really shown that the vaccination has worked. And I'm just wondering, in the population that still developed cervical cancer or SIM3 after the vaccination, do you think maybe there are more HPV genotypes that are responsible for that cancer? Or do you just think it's based on the fact that they might have had the HPV exposure before the vaccination?
Yeah. So I think at the moment you'll be seeing some cancers that are not HPV 18-16 related. And there is a whole program of work at the UK Health Security Agency genotyping so that we know what types they are. Once the impact of the 9-valent comes through, and we need to wait, I think, at least another 10 years to see that, then it's a different ballgame. I don't know. Good question. We'll have to wait and see what genotyping says. But at the moment, there are other types of HPVs that are causing the cancer.
Thank you.
So we have a question for Imad. Imad, do you want to unmute yourself and put your camera on, please?
Yes, thank you so much for the nice presentation. I'd like to ask about the vaccination for the non-sexually active ladies. Will it be still effective at any age, or it has to be at younger age?
Really good question. So there is a program called HPV Faster, where they're doing an HPV test to women during their screening, and if they're negative, they get vaccinated at any age. Well, maybe under age of 50. And that's going on in the developing world and has been quite successful. So the answer is yes, they are effective, but they're most effective if you know that they're negative to HPV.
Okay, thank you.
Okay, and there's also a question from Sam Riddle. Sam, do you want to put your camera on and unmute yourself and ask your question? Sam, would you like to ask your question? Sam has asked, does Alex have any thoughts on the use of HPV prophylactic vaccine in older women who have persistent high-risk HPV infection?
So I haven't seen the results of the trial, but it's a different vaccine. And I think it's looking good, but I haven't really seen it. This is being carried out at Imperial. So sorry, I can't comment on that.
So Ang, did you want to bring your make your comment? Do you want to just unmute yourself? Okay, so Ang has said equity and reproductive. Hold on, where are we gone? Equity and reproductive healthcare, women of hard to reach populations. Is anything commissioning based on these outcomes that you're aware of?
Yeah, I think we're moving to self-sampling. That might be a really good measure to get those hard to reach populations where women can take their screening test at home. And maybe that's, I don't know about vaccination, but that's a good way to get them screened at least.
Human, do you want to come back in and ask your question, please?
Yes, so should be offering to women vaccine when they had a history of CIN3 and they've been treated and the tests of cure now shows no HPV. It's a question they ask all the time.
I think not, because they already have natural immunity. And so I think that's the point, that once you have your natural immunity, the vaccination is less effective. You could offer it, but it's not going to be as great as if you have it when you're naive.
But there will be some level of protections.
They could be, because maybe they were positive to 18, or if you give the 9-valent, if they were positive to 18, they're now protected to all the other HPV types. So if you see it like that, yes, there is some level of protection.
Thank you very much.
Jay Shree from Newcastle, do you want to ask your question?
Yes, hi. Thank you for the great talk. Do you think in time that, you know, the HPV vaccination will also reduce incidence of HPV-driven vulval and vaginal cancers in women?
Yeah, so I think my answer is the same as for head and neck, because I think the proportion of those that are due to HPV is also much lower than the proportion of cervical cancer. But yes, it should definitely make an impact.
Brilliant, thank you.
Samantha Dixon, Sam, do you want to just come in and make your comment, or say
no,
what you want?
I don't think so. No, I didn't have my hand up, did I? Just commenting on the comment about inequalities, and that hopefully now we've got this NHS Inequalities Core 20+5 strategy that should drive commissioning to target less reached communities. Fingers crossed.
Okay. Are there any other comments or questions? Thank you very much, Alex. That's a fantastic talk. You know, that's shown the effectiveness of the cervical, the HPV vaccination program, and the good results that we're getting from that. May that continue. Thank you very much.
Thank you very much.
Thank you.
I'll hand you over now to Susie, who will introduce our next speaker in absence. Mark, are you ready with the video?
Yes.
Okay, Susie.
So up next, as Mr. Abdul says, in absentia, is Dr. Stephen Dobbs. So he's unable to be here today in person, but he has very kindly pre-recorded his presentation on where we are in the post-Black era.
So Dr. Dobbs, to give a bit of background, completed his undergraduate training at Queen's University in Belfast before completing subspecialty training in gynaecology in Nottingham. He's been a consultant gynaecology surgeon at the Belfast City Hospital since 1999, and he is current president of the British Gynaecological Cancer Society. Okay, Mark, if you want to go ahead and play, thanks.
Good afternoon. I'm Stephen Dobbs, a gynae-oncologist in Belfast City Hospital, and I'm also president of the British Gynae Cancer Society. Thank you for the invite. I'm afraid I'm not here in person, so this is recorded. Currently, I'm in Val d'Isère skiing, or maybe more specifically, I might be at lunch enjoying some refreshments. I'm going to talk about the surgical management of cervical cancer following the LAC trial. We're going to review the evidence regarding the LAC trial and the action that's occurred post-LAC regarding type of surgery that should be performed, tumor size, how to minimize potential spread of cervical cancer, impact on surgical training, and finish with some conclusions. So just a quick recap regarding my management of cervical cancer. When I trained in Leicester quite a long time ago now, I performed open radical hysterectomies and, if you like, cut my teeth on beautiful radical surgery, which, unlike quite a lot of other gynecological operations, is really an anatomical dissection. Following my early appointment as a consultant in Belfast, from around about 2002, we started to develop and operate on the Charter radical vaginal hysterectomy, pioneered by Daniel Darjon in Lyon and Nice. So this was really a laparoscopic pelvic node dissection and a vaginal radical hysterectomy. From really sort of the late 2008, following appointment of two new consultant colleagues in Belfast who had been trained in Toronto and also spent some time in Adelaide, we then started to do laparoscopic radical hysterectomies, initially with a vaginal approach, and then fairly quickly after that doing a total laparoscopic radical hysterectomy with vaginal excision and pelvic node dissection. That went on to developing sentinel node biopsies. However, more recently, certainly post-LAC, we've been doing a lot more open radical hysterectomies, but we still do some laparoscopic radical hysterectomies. So up to 2019, there was a really rapid development of minimal access surgery for cervical cancer. This was a new operation which was very popular and also very enjoyable. A lot of the safety indicated there was similar survival outcomes to open surgery. Minimal access surgery carries obvious advantages of shorter hospital stay, less morbidity, and became the treatment of choice. ESCO in 2018 wrote minimally invasive approach favored grade B evidence. And I would think it would be fair to say that a lot of the training fellows got little opportunity to do open radical hysterectomy, combination of rapid development of minimally invasive surgery coupled with a decrease in the incidence of cervical cancer meant that few operations were actually performed openly. That it was until a study was designed to prove the benefits of minimally invasive surgery to show grade A evidence. This study, as we all know, the LAC study, was stopped early, and results were published in late 2018 in the New England Journal of Medicine. The two papers published in the same edition, one was the LAC trial and one was the retrospective study of Melmood and co. So what did LAC show us? Well, it was a prospective randomized phase 3 trial, which despite some criticism still gave us grade A evidence on minimally invasive surgery versus open surgery. The initial study was to enroll 740 patients, but the trial was stopped early after recruitment of 631 patients due to the unexpected results. The trial included 1A1 with lymphovascular space involvement, 1A2, 1B1, and took squamous cells, adenocarcinomas, and adenosquamous carcinomas of the cervix. There was a fairly homogeneous group with 319 in the minimally invasive surgery, of which the vast majority were laparoscopic radical hysterectomies and a small percentage of robotic radical hysterectomies, indicating really the surgical approach at the time. The outcomes were quite startling in that 4.5-year disease-free survival was markedly reduced in the minimally invasive group compared to open surgery, and the 3-year overall survival was also significantly reduced. The conclusions were that the minimally invasive surgery group were more likely to have local regional recurrences with a hazard ratio of 4.26. Following the LAC trial, there was a flurry of publications both supporting and conflicting the LAC trial. I've already mentioned Melmood's paper published in the same edition of the New England Journal, which was an epidemiologic study with nearly 2,500 women. In this group, however, up to 80% of the minimally invasive surgery group were robotic radical hysterectomies. However, it still showed that MIS was associated with a higher risk of death compared to open surgery, and the adoption of one of the conclusions was that the adoption of minimally invasive surgery in the United States coincided with a decrease in survival of 0.8% per year. Several meta-analyses were performed, notably by Niteki et al., which looked at almost 9,500 patients which agreed with LAC, and several trials were also published, Chen, Campos, and Chiva, which in 2021. I'm going to come back and talk about the Chiva paper, which is the SUCCOR study. There were some conflicting reports, and notably from a British point of view, Pierre Martin Hirsch and a group of 8 UK cancer centres published a retrospective analysis of 779 cases of women treated with 1B1 cervical cancer and found no difference in mortality between the groups, but were able to point out mortality was associated with tumour size and lymphovascular space involvement. Biachi in 2022 with the Cervical study group showed no difference in 3 or 5-year survival, and several other papers, including the memory study, found no difference in progression-free survival and overall survival. Again, in the memory study, almost 80% of the group were robotic radical hysterectomies. The British Gynae Cancer Society issued a position statement in May 2019, which is almost 6 months after publication of the LAC study, giving some guidance on management of cervical cancer. It was quoted that in light of this analysis, i.e. the LAC trial, the BGCS recommends that clinicians and patients exercise caution when considering undergoing minimal access radical hysterectomy for the management of early stage cervical cancer. We recommend gynecological oncologists and nurse specialists counsel patients regarding potential risks and benefits of short-term morbidity. So where are we post-LAC? Well, the evidence has shown that there's been a rapid reduction in the involvement of minimally invasive surgery, and this varies from reports from 30 to 63%. The larger number is certainly in North America, and the incidence of minimally invasive surgery in North America has reduced by almost 2/3. There are conflicting reports on morbidity with abdominal radical hysterectomy. Matsu, in a report, in a paper, reported a 63% reduction in minimally invasive surgery, but associated with a 23% increase in postoperative complications. However, Frumovitz and Obermeier, which are reporting on studies which have followed on from the LAC trial, have shown no difference in adverse events and similar postoperative quality of life using the same population as the LAC trial. There has certainly been an increase in patient counselling and choice over management of their cancer. A lot of patients, when we speak to them in the clinic, are aware of the LAC trial, and if they've read anything at all, they will be aware of the need for caution and proper counselling regarding potential minimally invasive surgery. There may well be a lot of quite a number of reasons that could explain the dramatic results in the LAC trial. Was minimally invasive surgery associated with lack of radicality? Was the rapid uptake of minimally invasive surgery associated with a lack of surgical expertise, similar to reports that have arisen regarding robotic prostatectomy surgery, which expanded an operation that was not really performed prior to robotic surgery into a fairly common operative procedure, but there are some question marks regarding the expertise of the surgery carried out for prostatic surgery. Is minimally invasive surgery associated with spread of tumour cells from the cervix, and is it due to the surgical technique of tumour containment following colpotomy or manipulation of the cervix during the operation? So I'm going to look at each of these in turn. First of all, looking at tumour size. The LAC study was not powered for subgroup analysis, but the observation was made that the surgical approach only influenced risk of recurrence if tumours were more than 2 centimetres in diameter. This has since been supported by the SUCCOR trial. We all know from our basic science that tumour size correlates with nodal metastases and parametrial involvement, i.e. the bigger the cervical tumour, then the more likely there's going to be pelvic node metastases and parametrial involvement. The SHAPE trial, which looks at the role of simple hysterectomy versus radical hysterectomy in early cervical cancer, has completed accrual, and we're awaiting the trial results. This may shed some light onto whether radical surgery for very early cervical cancer is indeed necessary at all. There are many conflicting studies, and this may illustrate different criteria looking at tumour recurrence or assessment of the tumour size. For instance, was the cervical tumour assessed clinically or radiologically or histologically? Variations in in the size of the tumour will depend on the MTT criteria. Is the poor outcome due to presence of any macroscopic tumour rather than any microscopic tumour? So we are working on a hypothesis that macroscopic tumour is bad news. It seems sensible to say that tumour spillage will occur during colpotomy and manipulation of the cervix during radical hysterectomy. This can result in tumor disruption and implantation at the vaginal vault or intraperitoneal. As a proof of concept, a study in South Korea looked at ICG applied to the cervix and then assessed for peritoneal contamination. The results indicated that when parts of tubes that were infiltrated with ICG were sutured onto the cervix, peritoneal contamination occurred in 75% of the patients. The conclusions from this study are: do not perform minimally invasive surgery if macroscopic disease is present on the cervix. Do not use a uterine manipulator, which may aid in spreading cervical cancer cells intraperitoneally, and avoid intraperitoneal colpotomy. As proof of concept, I had a look at the role of ICG on the cervix. This is a case, actually an endometrial carcinoma case, and I injected a couple of mils of ICG into the endocervical canal with patient permission, and looked at the spread of ICG during the surgery. The main picture shows the IP ligament and the pouch of Douglas, taken 20 minutes following the start of surgery, which indicates ICG spread within the abdominal cavity. And although this is quite crude, it does illustrate that tumor cells can, or fluid can travel from intrauterine, cervical, and intrauterine into the abdominal cavity fairly rapidly during surgery. So what about macroscopic disease on the tumor? Well, one of the offspins of the SUCOR trial, which was an international European cohort observational trial comparing minimally invasive surgery versus open surgery for 1B1 cervical cancer, performed with a patient cohort in 2013 to 2014 within ESCO areas, looking at primary outcomes of disease-free survival and overall survival. However, an important part of this study showed that if patients had a cone biopsy performed as part of their diagnostic workup, rather than a cervical biopsy to diagnose the cervical cancer, they found that the risk of relapse reduced by 2/3 with the cone biopsy, and the risk of death from cervical cancer was reduced by 75%, albeit very small numbers. This is also supported by further studies, particularly by Kim et al. In 2021, which indicated that the conization group had a better disease-free survival compared to non-conization in minimally invasive surgery. And in the MIS group, the disease-free survival was, for this group of patients undergoing cone biopsy, was 95.7% versus 82.9%. And importantly, there was no change in disease-free survival whether you had a cone biopsy or a biopsy in the abdominal radical hysterectomy group. This would probably indicate that performing a cone biopsy prior to minimally invasive surgery may well be a beneficial step in removing visible tumor from the cervix. These results are replicated in patients with no visible disease on the cervix prior to surgery. Tumor spillage can occur. It is fairly logical to think that the V-care that illustrated here, which is inserted into the endometrial cavity, will dislodge tumor from the cervical, from the cervix, and this could travel either into the uterine cavity or could be spilt into the pouch of Douglas following colpotomy. Alternatives to intrauterine manipulators would be a McCartney tube or even rectal sizers. So following LAC with macroscopic tumor, it's probably better not to use a uterine manipulator. Again, The SUCOR study looked at subgroup analysis of manipulator use and indicated that there was higher relapse and poorer disease-free survival in group with uterine manipulators compared to the groups with no uterine manipulators. This is related to tumor size, and in patients undergoing minimally invasive surgery with no manipulator, the recurrence rates are similar to the abdominal radical hysterectomy group. So the other option for trying to reduce macroscopic tumor spread is to avoid intraperitoneal colpotomy. And again, when the colpotomy is performed extraperitoneally, i.e. vaginally, the outcomes are similar to abdominal radical hysterectomy in disease-free survival and overall survival. Patients undergoing minimally invasive surgery without vaginal closure had almost 3 times higher risk of death compared to abdominal radical hysterectomy. A simple principal rule of oncologic surgery is to avoid tumor spillage and tumor manipulation. These studies and results do support the logical conclusion that avoiding macroscopic tumor and spillage and manipulation would be beneficial to the patient. Following the LAC study, a lot of questions were raised by radicality. Is this the answer? Probably not. Studies have compared surgical radicality in robotic radical hysterectomy against abdominal radical hysterectomy and found no difference, but still robotic radical hysterectomy had inferior overall survival and progression-free survival. Is robotic surgery the answer? Probably not. In the paper published in the New England Journal of Medicine in 2018, Melamude in the minimally invasive group, as I've mentioned, had a very high level of robotic radical hysterectomy, and their results showed that there's no evidence that this was superior to laparoscopic radical hysterectomy. Is it technique related? It could be, but I think it's a bit too much of a heterogeneous group to assess that clearly. So what about our surgical approach following LAC? There are currently 2 prospective randomized controlled trials assessing robotic radical hysterectomy versus abdominal radical hysterectomy in early stage cancer. The RAC trial is a robotic assisted approach to cervical cancer, and it's a phase 3 randomized controlled trial which hopes to recruit 800 patients. Recruitment is ongoing. The ROC trial, which is robotic versus open hysterectomy surgery in cervical cancer, is hoping to recruit similar number of patients, but importantly, the ROC trial criteria insist that there is to be no manipulator, and there's a specific protocol regarding tumor containment before colpotomy. And the assumption is that robotic radical hysterectomy with tumor containment before colpotomy is non-inferior to abdominal radical hysterectomy concerning disease-free survival. The patients who are recruited to this study and centres that recruit patients must show photographic evidence of how the tumour has been contained prior to colpotomy. These trials will help to clarify if robotic radical hysterectomy with tumour containment as treatment for early stage radical hysterectomy is appropriate. So, in conclusion, the LAC trial represents a paradigm shift in the surgical management of cervical cancer. The publication of the study, it would be fair to say, sent shockwaves through the gynaecology community. However, on the back of that, even if the trial was designed to show how good minimally invasive surgery was, but didn't, the bottom line is that our patients deserve the best possible treatment for their cervical cancer. I think the way that the gynae-oncology community responded rapidly to the evidence of the LAC trial was admirable, and very quickly altered surgical approach and counselling for cervical carcinoma. Further studies will assess whether minimally invasive surgery has a role to play in management of cervical cancer. In our unit, we have somewhat in between approach to minimally invasive surgery and counselling our patients. We offer open radical hysterectomy for patients with visible tumour on their cervix, and we offer laparoscopic radical hysterectomy to patients with no visible disease, either visually or on MRI scan. I do find that some patients will prefer to have open surgery, and there are ways of reducing the short-term morbidity associated with this, for instance, transverse incisions, early removal of catheter, etc. But at the same time, a lot of patients will proceed with laparoscopic approach, and they're happy to take the evidence that if there's no visible disease on the cervix, then that is a safe way to proceed. We haven't yet started robotic radical hysterectomy for cervical cancer, and again, our numbers are reducing for cervical cancer, and it may well be that this operation will not be offered to our patients. Thank you for listening. I will finish with the recommendations overall that minimally invasive surgery for cervical cancer should only be performed in patients with no visible tumour, except within a trial setting. If proceeding to minimally invasive surgery, patients must be adequately counselled regarding risks of recurrence and death, and we should consider steps to reduce tumour contamination. Consider conisation rather than biopsy prior to definitive treatment. Do not use a manipulator, and consider performing an extraperitoneal colpotomy. Thank you for your attention, and I guess it's probably time that I should get back to the ski slopes. Thank you.
Fantastic. I think that's been a great presentation by Stephen. Any comments, any questions from anyone? I'll just make a comment myself. I think 3 years ago we ran this symposium again for cervical cancer, and the evidence was just coming through then. We were doing all our radical hysterectomies laparoscopically, and thought when things started to be said initially, my response was, well, it's probably just inferior surgery, people not doing the operation properly. But the evidence was very clear, and John Tidy came and did a fantastic presentation a few years ago, and we've certainly, as Dr. Dobbs has quite clearly said, the gynae-oncology community did respond very quickly, and there was guidelines from the British Gynae Cancer Society. And so certainly we've gone to just an open radical approach, but I think hearing Stephen Dobbs there, it's probably worth taking a halfway house approach, where we're potentially consider, if there's no macroscopic disease, then it probably appears from what he says that it may be an appropriate thing to do is to consider laparoscopic radical, or considering a knife cone biopsy before that. I don't know what other people's thoughts are. Hooman, did you want to come in here and unmute yourself? And
yes, I think you could go on and talk about this subject forever. I think we were all in peace until this LAC trial hit us like a tsunami, and then since then it has been never a day without facing not only being very truthful and transparent with our patients when we talk about level A evidence, but also think about the short and long-term medical legal aspects. So I mean, since this has started, I have been exchanging a lot of email with Pedro as well, And one of the things that we need to remember that we are all compliant with the NICE guideline, and the NICE guideline is very clear about carrying out any minimal access surgery in cervical cancer outside the context of research. Now, one of the things that I have given this talk about the LAC trial before, one of the things that we need to remember that there has always been the question about handling of potentially positive lymph glands when we're operating on earlier stage cervical cancer. That's something that not Pedro Ramirez or Andreas Obermeier, none of them were able to say. The patients who presented with later on with the distant metastases, whether we potentially would have not or should have not handled those micrometastases. Earlier stage cervical cancer, we've got a 5% chance of lymph node metastases. And on the other side, people talk about LAP1 and LAP2 trial in uterine cancer, saying, well, this was not the case then, but there's, as you mentioned, they're very heterogeneous. So we came to a conclusion that while we're waiting for the SHAPE trial to be published, we will talk about conservative study later on today, but until then, we will be really struggling to triage these patients to see which one I could potentially get away with minimal access, which one I will not. And until then, in Oxford, we have to come to a conclusion that the best is to play what is safe. Of course, we always put this across to the patient, and as you know, our CNS may play a major role in these discussions. But in terms of how we are obliged to be compliant with the NICE guideline, we have categorically decided not to consider this only for example, a stage 1A1, as much as I have spent years learning doing this laparoscopically, and it was the most enjoyable surgery to do on a weekly basis because of that beautiful anatomy. And we never use uterine manipulator, and we still don't use it even for uterine malignancy. But I think one should take it with a pinch of salt, be very cautious, and be prepared in years to come. If these patients come back with relapse, then you need to think what conversation was held, how it was documented, and how we practice the level A evidence. Thank you.
Thank you. I think you've got some very important points there. We, again, have taken a similar approach. We have completely stopped laparoscopic radicals, although that was our standard management. So we have to take the evidence on board. And when you've got such compelling evidence showing an increased recurrence rate internationally, irrespective of the quality of the surgeon, I think the only logical explanation is tumor contamination at the time of surgery. But I think, as Dr. Dobbs alluded, if there's some studies coming out saying that if there's no macroscopic disease, then potentially the outcomes may be better, and that may potentially be a way forward. Because we've all seen cases where we've got 1B2, which is small, and then LETS has virtually taken most of it away, and then you're left with a dilemma: do you do you still end up, and we've still been doing open radical hysterectomies on those tumours. So I suspect if the tumour's been taken away completely, but you still have to do completion surgery, then that may well be the point at which you consider that. Any other comments or query points? Any other oncologists want to tell us what their routine practice is? Sarah, what's your question in the meantime?
Hi, thank you. In Nottingham, we've converted every radical hysterectomy to open as well. I was just wondering if we're thinking about taking sentinel nodes forward. At what point do you do that? Do you do it with a handheld ICG device and do the whole procedure open? Because there are centres that I'm aware of that are still doing sentinel nodes laparoscopically, then full lymphadenectomy laparoscopically, and then opening for the rest of the dissection. But given the points we've just been discussing, if that woman was to have micromets, and given that we don't actually know the underlying reason for why women in the open arm had better outcomes, I personally think that's probably still too risky without further evidence. I just wondered what everyone else's thoughts are.
Uman, do you want to come in?
Yes, I think this is where people have been cherry picking from the LAC trial. I mean, when this came out, let's face this. We all failed to come to terms. This is level A evidence, and I have held these discussions, a colleague in UK and also in Europe, because people who were very comfortable with minimal access surgery, they had to somehow find something in between. I have chains of communications with Pedro Ramirez about this, and I think one which came out very clear is that two world experts in minimal access surgery did a trial to prove it's good, it's the right thing to do, and then they came to conclusion they should not be doing it. One thing which came out during these communications was, as you just say, that we should not be cherry picking until we have further evidence. So I'm very nervous and anxious when it comes to handling potentially positive lymph nodes, because you would never be able to know until you have further studies whether they are going to be fruitful or not in years to come. Potentially lymph node, which you will then with the CO2 disseminate to the carcinomatosis. I think we should not be the same thing with the, for example, radical vaginal trachelectomy, that people like to do the lymph node laparoscopically and then go do the rest of the surgery vaginally, something that we have been doing more than anything else in the last 20, 30 years. So your practice in Nottingham is exactly what we have adopted in Oxford, which is full compliance with the NICE guideline and really respect the level A evidence. We would like our patients to go home next day, and we are, and there is no shortage of the skills. But if those nodes are positive and you perhaps handle them, and we know there's a 5-10% chance of those, then you would, I think it would be very difficult to forgive yourself in years to come. We would be patient to hear about the RAC trial and other trials colleagues are doing in Far East, but I think we've got to be very cautious.
I think there's no evidence out there either way, Zehuman, as far as I'm aware. So I don't think we know the answer, Sarah, is probably the right thing. And Human said people are trying to cherry pick and say, oh, I want to do as much laparoscopically as I can because I'm a laparoscopic surgeon. How dare you take my radical lap hysterectomy that I've taken years to learn, and I'm phenomenal at it. You see the anatomy beautifully. And I was guilty of that to start off with, but when you see the evidence, it's compelling, and you have to just, you know, do ultimately with doing things for our patients. And one of the lessons certainly I learned as a sub-spec trainee and a junior consultant is that certain people like doing operations for the sake of doing operations, and you must not fall into that trap. And you'll still see people out there, and you'll know who they are, and they'll say, I like doing it because I like doing it. What's the evidence? Well, no, that's because that's what it is. But we're ultimately there for our patients, and we have to do what's best for our patients. We're not there on our own ego trip. Certainly I'm not, and I'm sure other people are not, but you know, there's certain people who will just do operations because that's what they want to do. Yeah. Okay, any other comments? Susie, shall we? Thank you. Shall we call it today? Unfortunately, Stephen's not here. And if anybody did have any further questions, we can forward them to Stephen if you wanted us to.
Yeah,
I think.
absolutely.
Okay, if we move on to our next speaker, Susie, I'll hand it back to you.
Okay, so thanks for all the great discussion points following the talk so far. So the next part of the programme is always a very special part of the programme. It's our patient experience. And this is where one of our patients who has already undergone treatment for cervical cancer very kindly agrees to come forward and share with us their experience and their journey. So Dr. Aisha Ashmore is going to introduce our patient, the patient's case history, and then she'll go ahead and share with us the video that the patient has made for you all today.
Hi everyone, can you hear me?
Yeah.
Yeah,
yes.
we can. Brilliant. So hi everyone, my name's Aisha Ashmore. I'm one of the ST5 trainees in Derby. So I'm just going to start off by telling you a little bit about Michelle, who's our patient who's very kindly shared her story with us. So I just want to check if you can see my slide.
Yes.
Brilliant. So I just want to introduce Michelle to begin with. So she was 44 years old at the time of her diagnosis. So she had a smear test done in February of 2020, which did show high risk HPV, but was negative on cytological assessment. So she was for a repeat smear in 12 months' time. Unfortunately, she then developed postcoital bleeding in June of that year and was referred to colposcopy. She had a cervical biopsy, and this confirmed a basaloid squamous cell carcinoma with grade 3 poorly differentiated histology with lymphovascular space invasion. So after that, she went through the gynae MDT and had an MRI pelvis, which showed pelvic sidewall nodes and essentially stage 3C was suspected, and as such she had a PET scan done, which didn't show any additional disease. So she then went on to have treatment with chemoradiotherapy, and she's going to discuss her journey through her diagnosis and her treatment with us today. So I'm just going to stop sharing that slide, and I'll just get the video up for you. And here we go.
My name is Michelle Cam, and I live in Nottingham. And in 2020, I had a diagnosis of late-stage cervical cancer. I also had cancer in my lymph node, in my iliac lymph node. My cancer was stage 3, grade 3, and it was very frightening to get this diagnosis. My lymph node was 4 times the size it should have been, and I had a tumour in my cervix, the size of a ping pong ball, so it was very frightening. I had no symptoms that I was poorly. I felt totally tip-top, I felt totally well. The diagnosis was a total shock, and I got the diagnosis in early July, and then literally 7 days after I had my diagnosis of possibly a 1B cancer, I was finding out that it was actually grade 3, stage 3 aggressive cancer, and my chances of survival were 50 to 60% chance of the treatment working. This news was like a bereavement. That's the best way of describing it. I've lost both my parents, and the news of cancer was exactly the same as losing a parent, exactly the same feeling, totally. I soon came to realise that I wasn't going to cry about cancer. I was going to have a tiny quick cry in the bathroom, and I thought crying is not going to send it away. And after about 2 weeks, I was all cried out. I just thought, I cannot keep doing this. I have to be my most positive, upbeat self that I can be. I wanted to be the strongest mum that my children had ever witnessed. I wanted to be the strongest wife that my husband had ever experienced from me. I just wanted to go. I wanted to go down happy. If that was the way, you know, if I was going down, I was going down happy. I was going down positive, and I was going down having fun. So I started radical treatment. I had chemotherapy for 12 weeks. I had radiotherapy for 25 sessions, 25 days of radiotherapy. And then after this, all this treatment, I had a procedure called brachytherapy, which is radiotherapy into the cervix. And then all this stopped on the October of 2020. And then I got my results that my treatment had worked in March of 2021. This was on the 16th of March. It was the best day of my life. I still stand by it now. It was better than getting married and having children, because it just meant that I could carry on loving and living with my family. It was a totally tremendous day. Such a euphoric feeling, just cannot put it into words how amazing that day was. So when I had my treatment, and my treatment was happening, I found a very lovely, loyal friend in the radiotherapy ward in the waiting area, and she too had the same cancer as me. So I felt instantly we had got this really incredible bond, that we felt like we knew what each other was going through. And you know, we knew each other's deepest, darkest thoughts, and she soon became a really incredible friend. So her name was Martina. Unfortunately, Martina's treatment didn't work for her, and she passed away in May. So when I got my golden news on the 16th of March, when I got the all clear, I knew that Martina's cancer had become terminal. So she now had lymph and bone cancer, and it was really hard to get my head around that I was now well, and I was going to lose my wonderful friends. You know, the bond I've made was not going to carry on. So on this day, I got a diary out of my computer drawer. I just found a tatty old diary, and I started writing feelings down. I'd not wrote anything during my cancer. I just decided to do the writing on the day of getting the golden news, because I felt my family wanted to see me bouncing off the walls. They wanted to see me happy. We wanted this nightmare out of the way, you know, wanted it gone. And now I was having to come to terms and accept that I was going to lose my friend that I'd made on the radiotherapy waiting areas. So I started writing in this little diary all my feelings about Martina. And it really does make me think, all these people that go through cancer, all the patients that go through cancer, whether their treatment works or whether it fails, we make such wonderful bonds with people who are also going through the same thing. And it's not really something I even considered or thought about until it happened to me. I also asked my husband to buy a motorbike because we'd had this hobby 17 years previous to me finding out I got cancer. And we'd had small children, and they were now teenagers when the cancer diagnosis came along, and I asked my husband to buy a motorbike. So it seems a very sort of unorthodox way out there thing to do when you've got cancer, but I really did want to jump on the motorbike every day, and it gave me such happiness. It was something that myself and my husband could do together. It was a hobby that we could do during lockdown. We could, because I was immune compromised, we could go out on the bike and we could have fun, and we could whiz around the country roads. It was such a tonic. So every afternoon we got the motorbike out, me and my husband did, and I was pillion on the motorbike. I had no hair under my helmet. We didn't know what was around the corner. I didn't know if I was going to make it to Christmas. And it was just such a joy to jump on the bike and have all this fun on the back of the bike and whiz up the slip roads, you know, and have all this fun and be going around the bends. And you know, it was so daring. It gave me everything that cancer was snatching away. It totally topped my heart up with the joy that I lacked. And I do still stand to this day and say that that was as important as the medication itself. So yes, having cancer, it's made me feel fearless. It's left me feeling inspired that you can't take a minute for granted. And just you have to just enjoy each day as it comes. Don't listen to this little monster in your head that says you can't do things. You know, we all stop ourselves doing amazing things, don't we? Just these doubts in our heads that we think we can't do that. You know, I can't possibly do that. I am proof that we can do anything. I've wrote a book. I've battled cancer and I've wrote a book. Hopefully every lady that reads my book will also be having a lesson all about the importance of cervical screening, which is obviously what I wanted to also do. I feel I'm a great advocate of that. You know, I really do want to push that it's so important to go for your screening. So this is the book. It's called A Lioness, and it is called My Story of Cancer, Courage, Love and Friendship by Michelle Cam. I just want to say thank you so much to Raw Dog. It's truly incredible how supportive they've been. So bye for now. Thank you for listening to my video. Bye bye.
Thank you. Hearing a patient experience has always been a good part of the symposium, and I think it's very brave of patients to share their experiences there. Any other comments from anybody else? So I think we're quite ahead of time this morning. I think we've probably got we're going to probably break for lunch shortly, but we'll probably give 5 minutes to our sponsor, one of our sponsors, Adriana Hopkins. So Adriana, if you want to come in here and just put your slides up or anything you'd like to say, and then subsequent to that we can break for lunch. Adriana, if you want to take unmute yourself and put yourself on the screen for a couple of minutes.
Yeah, I think I'm there now. Thank you very much. It's hard to follow the patient, but yes, she was excellent. And thank you. It's a pleasure to support this meeting. Very high caliber, and it makes me proud of Derby and proud to be local. So thank you. Yeah, my name's Adrienne Hopkins. I'm the Oncology Account Manager for the East Midlands, Cambridge and Mount Vernon. So some of you may have met me before. If not, I will put my email address in chat. And if I'm not your particular account manager, then I can direct you to who is. I just thought I'd use a couple of minutes to show you the website because there's some excellent resources on there. So just a couple of things to draw your attention to. The website is www.lymparza.co.uk. Make sure it's .co.uk because that's the one relevant to the UK. Obviously, our licenses in gynae are for ovarian cancer. So just making that clear today, we're talking about something slightly different, but I know a lot of people work across gynae. And one of the big things I'd like to show you that's on there is in the resources tab across the top. I'll just tap on that. And there's a few downloadable resources there that you can download direct to your desktop. Some of those are patient guides, some of them are around HRD testing. But this booklet in particular, Ovarian Cancer and the Evolving Biomarker Journey, is a lovely, very detailed booklet, really lots of pages about biomarkers, and you can download that direct to your desktops, or you can request the printed booklet, just key in your details on the form there. And then one other resource that people are finding useful at the moment is we've put the videos from our Ovarian Cancer Summit from last October on there, and there's some lovely videos that just play when you press on them, and there's Prof Lederman, Laura Tuckman, and a few others, Prof Sundar, who was on here last year doing her feasibility audit. There's an update on that, her NCRAS report. So they all just play. They're all about 15, 20 minutes long, and they're there for you whenever you want to watch. I'll put my email address in chat, and if you do need to reach out for anything at all, please feel free. Thanks very much for sparing the time, and I'll let you get on with the meeting and lunch. Thank you.
Thank you very much. Has anybody got any further questions or comments? I think Samantha's just put something in the chat forum just to remind people of the website. And it says, just a reminder, the forum is a great way for women with cervical cancer to find support and talk to others in a similar position. So I think just be aware of the Joe's Trust, please, and a source of support. But is there anything else, Susie, before shall we break for lunch?
No, I think that's probably everything, unless anyone has any other questions or anything else they want to discuss before we close for lunch.
So we probably got a bit longer for lunch. I think there was a suggestion possibly doing the trainees presentation earlier, but I think a lot of trainees are joining at about 1:30. So I think if we hold tight till then and just grab a more hearty lunch, if we all reconvene for about 1:30, try and sit back down for about 1:25. Have a great lunch, and we shall see you shortly, guys.
Okay, thanks.
Susie, are you still there?
Yeah, hi Dr. Liz, how are you?
Hi, I'm good. I'm just wondering if I could practice putting my slides up now, so I don't run into trouble. Are you happy if I just have a go?
Yes, go for it.
So if you go to the share icon in the top right hand corner.
Yeah.
And then click that, and hopefully your presentation, if you have it open on your desktop, should be available.
Yeah, let me just open it on the desktop, because it's sitting on the desktop but it's not open. So I'll do that.
Yeah, so if you open it and then minimize it, and then it should be there for you to select.
So I don't know if you're getting the message I'm getting. Mine's just saying reload.
No, that's coming up. Actually, the slides are there.
The slides are there.
You can see them. I get reload to display presentation.
That's fine. Do you want to just try and move it? Mary, do you want to try and move it along? Just press click.
No, because they're not showing for me at all. I'm getting a sign saying something's gone wrong when loading the presentation and reload it.
Do you want to try and stop? If you stop sharing and then try again.
Yeah. So stop sharing's on the left. It's the red button.
On the right.
Right. I've got to. No, that's. Sorry. I don't have a stop sharing.
It's on the left of all of the icons on the right. So it's to the left of those icons beside chat.
Yeah.
And it's red.
Yeah, no, next to chat it's blank. So mine goes, it might be in more,
Sometimes if the presentation wasn't fully open, maybe do you want to go out of the meeting and then rejoin?
And
Try
come back in
that.
again. Let
Yeah.
me try that.
Okay, we'll stay on.
Hi, I'm back again, Susie.
Okay.
That's
Perfect.
better. I've got it now.
Oh, great. Yeah, they're coming through. And do you want to just try and
wait for Susie to finish.
just to move through a couple of them to see that it works okay?
Yeah. So can
Right.
you just see the slide?
Yeah, perfect. I can just see the slide and they're moving perfectly.
And I've got my notes up, so that's all good. Okay, thank you very much for that.
Okay.
Okay, bye-bye.
Great.
Bye.
We'll see you soon.
See you soon. Yeah. See you. I'll sit in for the afternoon, so I can always jump in if you need it.
Oh, that's great. Okay,
Yeah.
thanks. So we're due to restart about 1:30,
Yeah.
1:25.
Yeah.
Okay.
Okay. Yeah.
Thank
Perfect.
you.
Thanks a lot. Bye-bye. Bye.
Bye. Bye.
Oh, hello. Is that Leslie? So it's Mary Lewis from Lymphedema Clinic. Hello. Hello.
Okay, guys, so we make a start again. I hope you've all had a good lunch. I think we've all went off to our level 5 canteen and had lunch together, which was lovely after lockdown and everything else. So welcome back to the afternoon session. Before we start, I've just put up a slide for our friends, which our friends at the British Gynae Cancer Society meeting have asked us to share with you. Just to let you know that obviously the BGCS annual scientific meeting is occurring in Aberdeen, as far as I know, this year on the 28th to the 30th of June. Registration is now open, and obviously we work closely with the BGCS, and obviously people are welcome to register for that meeting as and when. So that's the plug done for them, which is good. Okay, I'll hand you over now to Susie, who will introduce the afternoon speakers. Susie.
Okay, so yes, welcome back everybody, and we've got some really great talks ahead this afternoon. So we're going to kick off with what are our trainee presentations. So I will first introduce Aisha Ashmore. So Dr. Ashmore is sharing with us today an interesting case presentation. She completed her undergraduate medical training in the University of York, and she's currently an ST5 registrar here with us at the Royal Derby. She's just been appointed a research fellowship post in gynae-oncology, and her plan is to then pursue subspecialty training. So over to Aisha. Thanks.
Hi everyone, and thanks Susie for the introduction. I'm just going to start sharing my screen, so just bear with me. Okay, can everyone see my screen and hear me speaking?
Yes, yes.
Yeah.
Brilliant. Okay, so here we go. So I'm going to be talking about a case that we had a number of years ago in Derby of cervical cancer mimicking primary esophageal cancer at presentation. So I'll give you a little bit of background, but this is probably all very familiar to you from the presentations today. But cervical cancer, as you know, normally starts with local infiltration, and then the disease progresses in a stepwise fashion, initially invading the local structures and then going to the lymph nodes. Distant Mets normally represent a stage 4 disease and normally favour the liver, the lung or the bone due to hematogenous spread through the paracervical veins and the venous plexuses. So gastroesophageal Mets are relatively rare and only occur in about 2% of patients who already have advanced disease. So as you can imagine,